Hi everyone, just wanted to walk through the the airway assessment flowcharts with you. So airway flowchart number 1 and airway flowchart number 2. So right now we're looking at airway flowchart number 1 and starts off with the first questions, that is the patient presently oxygenating and ventilating adequately? If not, then we're going to head over to this orange side, which says inadequate ventilation. Crash airway is sometimes what this is called, and we need to rapidly correct this, presumably if we don't have adequate oxygenation and ventilation, cyanotic patient that's peri-arrest, if not into cardiac arrest. And the first thing that we need to do here when we recognize that somebody has inadequate tidal volume is that we need to try to address that with a bag valve mask. If we run into any difficulties with the bag valve mask, then 2 NPAs, OPA, and 2-person technique with the patient sitting up, if not contraindicated, should be incorporated. If that is not successful, then we should strongly consider the presence of a foreign body if that's ineffective. If we suspect a foreign body airway obstruction, then we should go in with our laryngoscope and McGill forceps and see if we can manage that, and then we would continue down kind of our treating of foreign body airway that may result in a surgical airway if we're unsuccessful with chest compressions and McGill forceps of getting that in. So if we have a patient that's currently not oxygenating and ventilating appropriately, and we put a bag valve mask on them, then they are now adequately oxygenating and ventilating, and we'll start to head down this green side. But this orange side is that we're going to rapidly try to correct their cyanosis with either a bag valve mask from least invasive to most invasive. We're going to consider whether an extraglottic airway device such as a King LT or iGel would be effective. Consider if intubation would be effective. And then finally we'd end up to a surgical airway. So you don't have to attempt each of those things. You need to be able to have considered them and defend that there was no chance of it being successful. So if you walked up to someone and they were missing most of their face, then bag valve mask, and you couldn't make a seal with anything, or you're justified that, then you wouldn't have to try a bag valve mask. You'd consider whether an extraglottic device was going to work or not, and if that wasn't possible to be successful, then you would have to consider intubation. If you thought there was no chance of being successful in intubation, your first airway might be a surgical airway. That would be an incredibly rare event. Often we show up and somebody's not actively breathing, we put a bag valve mask on them, and we're right back into this comfy land of the green that says we have time because we have adequate ventilation. After we have adequate ventilation, we're going to complete our assessment, including a physical assessment, history, and vital signs. We're going to make a differential diagnosis and a working diagnosis, and we're going to make a treatment plan, including transport decisions. We do not want to delay definitive care for a patient in order to intubate them. So there's times when you're on scene that it's appropriate to intubate a patient, and there's times that is not appropriate. Example might be a thoracic, some sort of big polytrauma that you're currently bagging well with a bag valve mask and not at risk of losing that airway. Rather than spending time intubating that patient, far better to get them to the trauma center where there's more hands to manage that patient. Obviously, whatever you can do en route to hospital is useful, but you're going to have to make that decision about when airway needs to be captured in balance with all of the other priorities, such as given fluid and TXA and splinting things and those types of interventions. So after you've completed those things and decided that it's time to intubate a patient, if you've completed the assessment, made your differential diagnosis, and decided that it now is the appropriate time to, in your treatment plan, and that it doesn't delay definitive care, that now is the time to intubate, then you'll ask yourself, do I need sedation or paralysis as required? So someone that might not need sedation and paralysis would be something like the return of spontaneous circulation in a patient that's had a long cardiac arrest, that's completely unresponsive and is not likely to have any gag reflex. Often those types of patients are intubated without any sedation or paralysis if they remain completely unresponsive after after cardiac arrest, and having had a ROSC and still requiring bag valve ventilations. You may choose to intubate those patients without any sedation. If sedation is required for the normal patient, we show up, let's say a COPD patient that's in respiratory failure, that you have bag valve mask on, let's say that you're going to have a more prolonged treatment or transport time, and there's no delay of definitive care that you can see, then you may choose to intubate that patient in their home, and you're going to intubate them using a bars approach, which is George Kovach's approach of approaching the airway from kind of least invasive and then getting yourself, so bars, bougie, I guess best look, bougie, bimanual, is a few of those things under that, and burp, external laryngeal manipulation. An alternate intubation device such as a King Vision or something along those grounds. Then rescue airway. If you've tried more than 3 attempts at intubating your patient and not successful, then you'll do that, go to a rescue airway. And if rescue airway isn't successful, such as an extraglottic airway, then you'll try bag valve masking. If bag valve masking doesn't work, then you would have to go to a surgical airway because you're at a can't intubate and can't ventilate situation. So if you require sedation, then we're going to intubate using a bars approach. And we're just going to flip over to airway flowchart number 2 and kind of look at how we'll approach for this patient that sedation and paralysis is required.